ACL tears are common here in Colorado ski country. Dr. Rick Cunningham of Vail-Summit Orthopaedics primarily sees them in skiers, but also in young athletes playing other cutting and pivoting sports such as soccer or basketball.
Most patients, when they tear their ACL, immediately feel a pop and a giving way in the knee. And the pop is the ACL ligament itself tearing, and also the femur, the thigh bone, striking the tibia bone, the shin bone. So some people even report two pops. A severed ACL, when you look at it in the knee with an arthroscope, looks like a rope that's been torn in two and is almost like two mop ends, where the ligament is torn in half and the ends of it are separated such that they cannot rejoin and heal themselves.
Techniques for surgical replacement of the ACL have advanced considerably in the past decade. Dr. Cunningham is among an elite group of orthopedists who perform a large number of ACL reconstructions each year. He believes that the key to a good ACL reconstruction is to restore the patient's anatomy as close to the original as possible.
Everyone's ACL is not the same. They're different sizes, different diameters. The insertion points are slightly different from patient to patient. Someone's ACL who's, let's say, a 100-pound ballerina versus a 300-pound lineman has a very different looking ACL. And therefore, I think it's critical in surgery when we're trying to reconstruct that ligament to look at someone's native anatomy, look at, where the ligament once attached on the bone and reproduce that perfectly. Currently there's some commercial guides available to surgeons. The guide positions the ACL graft in the same place every time for any given patient. But I don't use that guide because, again, I think everyone's anatomy is slightly different, and I want to look at how your ACL is different than another patient's ACL and put it exactly where it once was.
Various devices are used to hold the tendon in the bone before the bone grows into the tendon graft and fully incorporates it. These devices include small, low-profile screws made of metal or biocomposite material.
I prefer biocomposite fixation devices to hold an ACL graft in the femur and the tibia. These newer biocomposite devices are very strong, and the advantage is that over time they turn the bone. And a further advantage is you can get an MRI scan of the knee with metal in the knee, but it can distort the images, whereas these newer biocomposite materials don't distort the image like a metal screw would.
Finally, after reconstructing a patient's ACL, it's critical to get the patient into an accelerated rehabilitation program. We're very fortunate here in the Colorado Rockies to have a number of great physical therapists. These therapists are very active people themselves and understand patients wanting to get back to their prior level of activity.
In addition to physical therapy, I see patients in the office at regular intervals just to make sure that they're hitting all their milestones and that they're where they should be in terms of range of motion and strength and functional activity. Patients will ask me, when can I run? And typically that occurs at 3 to 4 months from surgery. Things like cutting and pivoting sports such as skiing and soccer, that's usually 6 months.